All right, well, it's 4:01, so welcome to Grand Rounds today in what we hope will be the first in a series of endocrine debates. Much to the chagrin of our presenters today, they are the first in line here. So it's my pleasure to get to introduce our presenters today, and I'm happy I can do this just off the top of my head without any script whatsoever. So our first presenter is Dr. Brad Javorsky, who I've had the pleasure of knowing for 18 years, yeah. I believe that we met in Toronto. So Dr. Javorsky received his MD from UW before moving to Virginia for residency and fellowship training. And then our second presenter was lucky enough to recruit him back here to Wisconsin, where we both started in practice in July of 2008. Since that time, he's been a fantastic clinician, I can say friend and colleague, and is currently an associate professor of medicine in our division of endocrinology and molecular medicine, and the head of endocrine at the VA. And then before I turn it over to you, Brad, I'm also going to introduce our second presenter, Dr. Jay Findling, who really needs no introduction in this room or elsewhere. I'll skip where you went to grade school and got all your other degrees. I'll say you got your undergraduate degree from Notre Dame. I know you're very proud of that. Before you were a fellow at UCSF, where was part of the team that made some seminal discovery about the use of IPSS in the differential diagnosis of Cushing syndrome, and came here back to Milwaukee, and for many years has been really a cornerstone of endocrinology practice and teaching, and nationally and internationally recognized expert in cortisol and adrenal disorders. And I can also say that you've been a fantastic mentor, colleague, and friend over the past 18 or so years. So without further ado, I'll turn it over to the two of you.
All right. Hopefully this won't be too contentious here. We'll get along all right. No blood or bruising here. Okay, let's get started. So here is my disclosure. I guess the big disclosure is that Dr. Findling's my mentor. So I have no choice but to let him win today. So this last weekend, my wife asked what I've been working on the last couple of weeks. Well, I'm going to debate Dr. Findling, and she's like, "What are you, stupid? He's going to crush you. He's going to make you. He's going to humiliate you." And I was like, "Oh, geez, thanks a lot." She's like, "What do you know about hyperaldosteronism? Was Steve McGill not available? I mean, what's going on here?" And I said, "Well, no, I really want to do this. I had kind of mentioned to Ty, I don't know, a year ago about this topic because I had seen a number of patients with referred for hyperaldosteronism, but none of them had primary hyperaldosteronism, all secondary. So I was getting frustrated, and I said, we need to think about this a little bit more. Let's debate it a little bit. And so I didn't actually think you were going to ask me to debate, but when you did, I said, well, I can't back out. And then I heard Dr. Findling was going to be doing it, so I said, no, I got to do it. And it's hard to believe that we've known each other for 18 years, which means that I've known you for half my life, exactly 50% of my life. So yeah, and it's really hard to overstate the impact that you've had on my career, my life, and so I owe you so much. And anything I've accomplished, you've had a hand in. So thank you very much. And I could say without exaggeration that this today is probably one of the highlights of my career. Be able to have this debate, this talk, and share the stage with you. So thank you very much for all you've done over the years. And by the way, that picture, that was from 2019. I took that picture when Dr. Findling won the Outstanding Clinical Practitioner Award at the Endo Society. So today, our objectives are going to be review the role of primary hyperaldosteronism in hypertension, review the current guidelines for screening of primary hyperaldosteronism, and understand the pros and cons of screening hyperaldosteronism in all patients with hypertension. So we're not going to vote, I don't think, on who's going to win this or lose this, but I want you to think as we're going through these talks today, a couple questions. So currently, do you test everybody that's high risk for hyperaldosteronism? Do you already do that? And after today, will you screen all the patients with hypertension for primary hyperaldosteronism? It's one thing to say you will, but to actually do it, are you going to do it? And a year from now, after screening a bunch of people with primary hyperaldosteronism, are you still going to keep doing it because of some of the issues we'll talk about? And do you think all providers everywhere should be doing this? Or is it just endocrinologists? Or is it just primary care? Who's going to be doing all of this? So be thinking about some of those things when you decide, what you would do at the end of this. So here's my arguments. I'm going to go through each of these briefly and give you some information, but here's the arguments I'm going to make against universal screening. So first of all, hypertension is not just essential hypertension versus primary hyperaldosteronism. I think sometimes we may be oversimplifying it, saying it's one or the other, but there's a lot of other stuff going on. We have to think about all those things. We're not even doing a very good job screening the high-risk patients, so maybe we should be starting with the high-risk people first. The current testing is not good enough. What do I mean by that? Well, there's a lot of false positive, the sensitivity is not great, the specificity, what are the cutoffs? Should we be using renin activity or direct renin levels? There's a lot of unanswered questions there. Much of the hyperaldosteronism we'll see is not a primary aldosterone secreting adenoma, but it could be due to a lot of other things, secondary hyperaldosteronism and obesity, for example. We have good medications to reduce aldosterone activity, and we will have good medicines in the near future that will reduce aldosterone levels. So we have medicines that could treat this. There are potential for complications with the testing and the treatment. There's limited resources, and there's a lot of cost associated with this. So I'm going to go through some of these arguments. So because this is grand rounds, I think I'm legally obligated to do some background on this, just for anybody that doesn't know all about the renin, angiotensin, aldosterone system. But I'll make it quick. But I just think it's really, really cool and elegant how 5 different organ systems all work together to make sure that they're getting an adequate blood supply. So you have the liver and the lung and the kidney and the blood vessels and, of course, the adrenal gland. They're all working together, making different components of this system. Renin is released from the kidney in response to low sodium, high sympathetic nerve activity, or decreased blood flow. And angiotensinogen, which is made by the liver, is cleaved to angiotensin 1, which is cleaved to angiotensin 2 by angiotensin converting enzyme in the lungs. And then, of course, angiotensin 2 causes release of aldosterone from the adrenal gland, which has its effects in the kidney, causing reabsorption of sodium and water. And aldosterone is made by the adrenal cortex, and the last few steps are synthesized by aldosterone synthase. So that's an important thing that we'll come back to later on, but that's an enzyme that's in the zona glomerulosa of the adrenal cortex. So here are the published guidelines, and there's not a lot of words on here that you actually need to read, but the point of this is the published Endocrine Society guidelines from 2016, and there's a bunch of different societies that have signed on to this guideline, including the American Heart Association, the European Society of Endocrinology, and the Japan Endocrine Society. And basically what they recommended is that you screen high-risk individuals for primary hyperaldosteronism. So this is the list that you're familiar with. So it looks a little complicated, but the bottom line are these are patients with high blood pressures that don't respond to several medications, hypokalemia, adrenal adenomas, and family history of primary hyperaldosteronism. I think really the only one that's kind of a surprise on there is the sleep apnea. But the rest of them are kind of common sense things you'd think about. Yeah, this person should be screened for a secondary cause of hypertension. And this, by the way, you might say, well, this might be a perfect place for AI to get involved. If we have AI to get involved in reading through our charts and saying, hey, maybe you should screen this person for primary hyperaldosteronism. That might be a good place to use it. And they recommend using the aldosterone-renin ratio followed by confirmatory testing. In 2021, the Japan Endocrine Society actually came out with their own guidelines, and this time they actually recommended that you should screen everybody with hypertension, especially those with high-risk hypertension. However, they go on to say, oh yeah, but 30 to 50% of people with positive screening will not actually have primary hyperaldosteronism. And in contrast, you can't totally exclude it either, even with negative screening because of the low sensitivity. So you're gonna, over test, and you're gonna get a lot of these positives. And then they even say you can't exclude primary hyperaldosteronism when the confirmatory test is negative. So you can't even trust a confirmatory test. So they point these things out, but at the end of it, they say, yeah, you should still screen everybody. The British and Irish Hypertension Society published guidelines in 2023, and they basically go back to saying just screen the high-risk people. So this is one of my points, is that hypertension is complicated. So we can't just say it's essential hypertension versus primary hyperaldosteronism. So when I was in medical school, Ted Goodfriend gave a lecture about a mnemonic for the secondary causes of hypertension. And I still remember this. It's A, B, C, D, E, F recaps. And so there's a list of things that you have to think about when you're thinking about hypertension. There's alcohol, brain lesions. Remember, this is the Cushing reflex, which is different than Cushing syndrome. Coarctation of the aorta, drugs like cocaine, methylphenidate, phentermine, glucocorticoids, estrogen, fatness or obesity, renal artery stenosis, endocrinopathies, which is kind of a grab bag for things like hypercalcemia, for thyroid disorders, growth hormone excess, Cushing syndrome, hyperaldosteronism, pheochromocytoma, and sleep apnea. So it's a long list of things to think about. And if we only screen for primary hyperaldosteronism, we're going to be missing a lot of stuff. And if you look at that chart there, you have to also keep in mind that which one is most common depends on the age of the person. So if they're young, it's not going to be primary hyperaldosteronism. And even in the people who are over 65, it's not primary hyperaldosteronism is the primary thing. So you sort of got to keep in mind the age and that there's a lot of other stuff going on. So we can't overlook those things when you're thinking about looking for causes. Another thing I think is really interesting is the association between obesity and hyperaldosteronism. So we all know that that hypertension is much more common in people who are overweight. A huge percent of the attributable risk of hypertension is due to excess body fat, and the increase in hyperaldosteronism coincides with increases in worldwide obesity. And it's been shown since the 1980s, or even younger, or even earlier, that obese individuals have higher aldosterone levels than lean individuals. Studies have shown that adipocytes produce angiotensin II, aldosterone, adipokines that cause secretion of aldosterone, and free fatty acids that also do it. So there's a link between obesity and hyperaldosteronism. And there's a whole body of literature that's actually looking at how obesity may be an underlying cause for what some people call idiopathic hyperaldosteronism or bilateral adrenal hyperplasia. So, another thing to keep in mind is that we sometimes we'll kick around this number saying that 10 to 15% of people with hypertension have hyperaldosteronism as an underlying cause. And really, though, that's not totally true because it depends on how bad their hypertension is. If you just look at people with kind of mild hypertension, stage 1, it's only 2%, whereas stage 2, it's 8%, and stage 3, it's 13%. And it also depends on what aldosterone to renin activity ratio you're using. In one study, they found that only 0.7% of patients in a primary care clinic actually had confirmed primary hyperaldosteronism. So if you're looking at a low-risk population, you're much less likely to find primary hyperaldosteronism. And this chart, again, don't expect you to actually look at it, but the point here is that a lot of different groups have investigated the prevalence of primary hyperaldosteronism, and they find a huge range, but they use a huge range of aldosterone to renin ratio. So it depends on what ratio you use to help you decide if the patient has primary hyperaldosteronism. And in these studies, it's anywhere from 20 to 50. So which ratio do you use when you're deciding if somebody has primary hyperaldosteronism or a positive screen for it? This is a study that was done at the Mayo Clinic on 118 patients with mild to moderate hypertension, and they found that 15 had primary hyperaldosteronism, which is about 10%. And but when you look at what the ratio was in those patients, only about half of them had a ratio that was above 20. So they defined primary hyperaldosteronism as a renin activity less than 1. and a 24-hour urine aldosterone greater than 12. And they actually found that the greatest sensitivity and specificity was at a ratio of 12.4. So if they used an aldosterone to renin ratio of 12.4, then the sensitivity was 73%, specificity 74. And if you look at the positive predictive value, it's only 29%. So that means a lot of people who test positive are not going to actually have primary hyperaldosteronism. So here's a question. In the published guidelines from 2016, what aldosterone to renin activity ratio do they recommend? What do they say? This is the one you should use. Well, it's a trick question because they don't say. They don't actually say what the ratio should be. They say, here's some ratios. Some people use this. Some people use that. Depends on the test. They go on to say that. So what cutoff do they recommend in those guidelines as far as like when if the aldosterone is below a certain level, the patient does not have primary hyperaldosteronism? That's a trick question because they don't really say. They'll say 10 is probably a good number, but it could be 15. We don't really know. And a bonus question, if you look at the up-to-date guidelines, what ratio do they use or they recommend you use? Well, they don't like the ratio. So they like saying that you should look at an aldosterone and a renin activity level and kind of look at them independently and say, this patient has a positive screening. So what test do we use? And do we even use renin activity levels, or do we use direct renin levels? So, there's a lot of unanswered questions about this. This chart also is just meant to kind of blow you away with the complexity of testing. So on one side, the guidelines say, look at all these things that cause false negatives and false positives, all these drugs, whether, what age a person is, if they're on estrogen, if their kidney function is abnormal. You got to think about all these false positives and false negatives. And then the other side here just says, here's the optimal way to test. And they go through all these steps you got to do. You got to make sure their potassium's normal and they're on the right medicines, and it's done in the morning, 2 hours after they've been sitting upright. And so there's a lot of things to go through. And so who's going to be doing all this testing? Who's going to, and what percent of the time is it going to be done correctly? That's an important question. Another point to make is that, we don't do a good job, even in the high-risk group that have a pretty high percent of primary hyperaldosteronism. Studies show that about 2 to 4% of people that meet the criteria in the Endocrine Society guidelines gets screened. So we're not testing people at all. And if you look at a University of Michigan study where they actually include a best practice alert, it pops up on the screen and says, your patient has these high-risk features, you should order these tests. And it helps them order, even then, only 14% of the time that they actually start ordering it. So we just need to do a better job testing the people who actually meet the criteria for it. We have a lack of infrastructure. If you figure that about 48% of adults have hypertension, that comes out to about 122 million. And there's only about 1,000 endocrinologists. So if we screened everybody, if it came down to us, then we'd each have to do 14,800 patients to screen, each of us, in order to screen all of them. And if you only screen 10% that were positive, let's say, of course, that comes out to 1,480 per each of us. So even the ones that are positive, so it's a huge number of people. And then what about the confirmatory testing? Can we do these things at all different sites? We can do it here, we're lucky. But what about in the middle of Wisconsin or in the middle of some other state in the rural area? Can we do saline infusion tests and fludrocortisone suppression tests and all these other different confirmatory tests that are recommended in the guidelines? And then, of course, the limitations in interventional radiology, adrenal vein sampling. We're lucky here, but in a lot of places we just don't have those options. The costs are high. There's clinical risks. If you tell people to stop medications in order to go on other medications, they can have problems with hypertensive emergency. They can have volume overload from some of the confirmatory testing. You get false positive results, and so patients are very anxious. You find incidental things on CT scans. There's complications with some of the tests we do, like adrenal vein sampling. And then there are complications from surgeries if we end up sending them on to that. There's a lot of economic risks, for a lot of these tests. CT scans, adrenal vein sampling obviously are very expensive. And then there's the societal risks. Again, we have limited resources, and we just don't have a place to send everybody for confirmatory testing and adrenal vein sampling. So a lot of costs. So I'm going to close by talking about something you're probably going to be hearing a lot about if you haven't already heard about these drugs, because I think within the next couple of years they're going to be available, and people will be talking about them and advertising them. And you hear a lot about treatment-resistant hypertension. So this class of drugs, they're going to go after, say, treatment-resistant hypertension, people who don't respond to these 2 or 3 other medications. It's because their aldosterone levels are too high. Put them on an aldosterone synthase inhibitor. So aldosterone synthase inhibitors inhibit aldosterone synthase, the final several steps in production of aldosterone in the adrenal gland. And they're very specific. They don't interfere with 11-beta hydroxylase, which is the enzyme that makes cortisol. So it doesn't interfere with cortisol production. But they work pretty well in lowering blood pressure. And these are the drugs that I've seen most recently as far as getting along in the studies. I don't really know how to say them: lorundrostat, baxdrostat, and vicadrostat. But they seem to be doing pretty good. There was a New England Journal study that just came out a month or so ago, and they talked about the efficacy in patients with uncontrolled hypertension. And I think it's important to point out that in these studies, they don't actually test or screen for primary hyperaldosteronism beforehand. They just have somebody with uncontrolled hypertension on multiple drugs. They put them on these drugs, and they do pretty well. This is one of the figures from that paper, and it shows that this drug lowered blood pressure by 15 points, so it worked pretty well. And these are patients who are already on 2 or 3 other drugs. So I'm going to end with my recommendations, which is to start screening the high-risk patients first, utilize best practice alerts or AI to help with screening. We need to screen more people that actually meet the criteria. Think about all secondary causes of hypertension. Don't just think about primary hyperaldosteronism. We need research to better define what is the aldosterone to renin ratio we really should be using. What are the aldosterone cutoffs? What confirmatory tests should we use, and what cutoffs for those confirmatory tests? We should treat obesity, because that might also help to lower aldosterone levels. And we need to be more aggressive about treating hypertension. I think a lot of times we see it in our clinic, and we don't really do anything about it. And we should think about using medicines like spironolactone or eplerenone in a lot of these patients. And soon, coming down the road, we will have another option, which are the aldosterone synthase inhibitors. So we'll be thinking about those as well. So in closing, I just want to acknowledge again Jay Findling and all the mentors out there who help us. And I learned so much in fellowship, but I learned 100 times more in my first 5-10 years out of fellowship from these guys and gals. So I really appreciate it all, and so thank you to all of the mentors out there.
That picture was Brad and I at a Brewer playoff, I think a pro playoff game. Right?
Yeah.
I think the Brewers lost it, unfortunately. Yeah. First of all, I want to just thank Brad for the kind things he said about me, but I can't tell you how fortunate I feel to have recruited him from the University of Virginia to join us 17, 18 years ago. And I'm very proud of the progress and the things that he's done. I'm really proud of him. I mean, he's chief of medicine at the VA, or chief of endocrinology at the VA, and he's just been a great colleague and friend. This morning, I told Judy, my wife, she asked me, why are you working on Thursday? I said, well, because I couldn't play golf this morning because the course is full with other things. And I said, I have to debate Brad. And, you know, 'cause she didn't understand primary aldosteronism, but I had this debate with Brad. She loves Brad. And then I told her, I said, you know, what's not known is that Dr. Kadami is going to fire whoever loses the debate. And so, and she says, I'm rooting for Brad. I'll give you some idea how she feels about me working, I guess. But I have some disclosure. So I think we need to have a little background about primary aldosteronism. This used to be an endocrinopathy formerly known as Kahn syndrome. And Jerome Kahn studied the acclimatization to hot, humid climates of the Pacific Theater during World War II. Actually, my father was in the Pacific Theater during the Second World War. And he looked at sweat chloride, which was sort of a surrogate of sodium loss, and which declined to very low levels after 3 days. And he had a hypothesis that electrocortin, that's what he called this, mediated the sodium reabsorption. Of course, just a few years later, aldosterone was synthesized. Then he went on to work with Steve Fyans, which is one of his first fellows at the University of Michigan. And I think Dr. McGill actually is trained with Dr. Fyans. So there's just somehow a connection here. And they described the first aldosterone secreting adenoma in 1953. And in his first publication, he predicted that 10% of all patients with hypertension would have this. And of course, you can't imagine, everybody thought he was an idiot. He turned out to be a prophet. So, and I think one of the things we need to understand is, and this term primary aldosteronism is probably not maybe the greatest term because, you know, it turns out in adults, at least in the United States and probably all over the world, I mean, our sodium intake is about 3.6 grams a day. That's the average in the United States. So we should make any aldosterone. I mean, normal people shouldn't make any. In fact, if you look at adrenal glands in adults, there's no contiguous zona glomerulosa and aldosterone producing cells. You can't find, if you look at CYP11 beta 2 immunocytochemistry, you can't find any aldosterone producing cells in adrenal adults. Almost none. But adults under the adrenal capsule harbor these aldosterone producing micronodules, and driver mutations and mutations can cause maybe a forerunner of adenomas in some patients, or what we call hyperplasia. So I'm not sure we should make any aldosterone. And maybe that's why aldosterone synthase inhibitors are so potent. I mean, remarkably potent in reducing blood pressure, because that's the only mode of action is at lower aldosterone concentration. And that's why spironolactone now is probably the drug of choice in patients with resistant hypertension by hypertension experts. So my objectives today is really to introduce the rationale for screening all patients with hypertension for primary aldosteronism, which will be included in the forthcoming guidelines for the Endocrine Society, which I did share with Brad. I went on the dark endocrine web and got a copy of this ahead of time, but I did share it with Dr. Javorsky. And to appreciate the use of direct reading concentration as a new measurement of renin at Wisconsin Diagnostic Labs, which we're in the process of getting set up, and as well as an immunoassay rather than tandem mass spec for aldosterone, just to increase the turnaround time, with the acknowledgement that I think more screening will be done, hopefully. And then recognize that the other steroid, that is cortisol, of course, that's the one I'm most interested in, binds with equal affinity to the MR and corticoid receptor, and why that's important. And I'm going to briefly review CALLUS and predict what the new study just starting this summer, Momentum, may share with us. So this is the new clinical practice guidelines that I think will be published this year. The authors, Gail Adler, who's Gordon Williams, a disciple at Brigham and Women's, and of course Anand Vaidya is on there, and of course Bill Young. Some of you people I'm sure all know Bill. So what is the evidence for recommending PA screening in all patients with hypertension? And this is, again, the rationale from these guidelines. Well, the condition must be an important health problem. Well, I think we all agree that it's a frequent cause of hypertension. How frequent? I may disagree a little bit with some of the data Brad showed, but primary aldos are independent of hypertension, associated with increased mortality and morbidity if untreated. In other words, there's a difference between treating patients with primary hypertension and patients with primary aldosteronism in terms of outcomes. Now, how common is this? Well, I have found this study because I thought this is just hilarious when I read this. I started laughing. So there's now an association between, this was just published a couple of months ago, between papillary thyroid cancer and primary aldosteronism in individuals with hypertension. I'm sorry, I forgot where this came from. It's in the US though, I think. They looked at 137 patients with primary papillary thyroid cancer, 48% with hypertension. And they did 137 controls with hypertension, BMI, sex, age match. And they diagnosed 29% of patients with PTC had primary aldo and 20% of the controls. And I started laughing at 20% of the controls, 29. I mean, it's not any different as far as I'm concerned. But they've got statisticians that did all sorts of machinations and figured out that somehow papillary thyroid cancer increases the risk for patients who have hypertension. They have a high risk for PA. Now, this study, I think, is probably the most elegant, and it was done by Anna Vaidya at the Brigham and Women's and just published 5 years ago in the Annals of Internal Medicine. And what they did is they looked at urinary aldosterone on high sodium diets and looked at patients who had low renin. Okay, they had to have low renin to enter the study. And in normotensive patients, 11% did not suppress their urine aldo less than 12. Stage 1 hypertension, it was 16%, and patients with treatment-resistant hypertension, it was 22%. So they did the confirmatory study, no aldo to renin ratio, just low renin levels. I can't remember what the renins. I assume less than 1 nanogram per ml per hour, or less than 8 on if they did direct renin concentrations. So it is common. I think everyone acknowledges that. And I think, as Brad said, we all also recognize that screening is pretty horrible. This is a study from 2021 at the VA. A lot of vets with resistant hypertension, and the screening rate was less than 2%. But those patients who were screened for PA had a much lower blood pressure over time and a fourfold increase in the use of mineralocorticoid receptor antagonist therapy. And then there's a Canada study, less than 1%, and Brad showed you some studies. So I think we all acknowledge that screening is just not adequate. About 7 or 8 years ago, I was talking at CEU. I don't remember where it was. Doesn't matter. And Bill Young was also on the program in the Adrenal, and he was talking about primary aldo. And at the end of his talk, this is 7 or 8 years ago, he said, everyone, hypertension should be screened for this. And I thought that was crazy. And then I started thinking about it. I think he's right. Because, I think he might be right. And so now I do this routinely, and I'll bet I find 4 or 5 people a year who have PA, often not neoplastic hyperaldosteronism, but at least PA that may benefit from mineralocorticoid receptor antagonist therapy. So I think there is something to be said about this, and I want to introduce the idea that we're now, or soon, we'll be, instead of measuring plasma renin activity at MCW and Freighter, we'll be doing direct renin concentrations. So you have a little flavor of what this is going to look like. So again, I'm one of the things, I don't even look at ratios. I think ratios are just dangerous things to look at. I think you need to know. In fact, I saw a patient, I just told the fellows, Jack, I think, the other day, yesterday, or a couple of days ago, I saw a patient who I worked up 3 years ago, never came back, had diagnostic testing for primary aldo, and came in. This time I did another aldo renin ratio. The renin, of course, was undetectable. Patients on I think losartan, and the aldo was undetectable. And I said, does that rule out primary aldo? I said, and Jack, he was kind of I said, no, probably still has primary aldo because his potassium is only 2.9. So when I correct his potassium, his aldo is going to be 8. And he's probably going to have primary. Probably this lady still has primary aldo. So, but anyway, so I look at the renin and the direct renin concentration less than about 8 or 9, plasma renin activity less than 1, and an aldosterone if you use immunoassay, which we will be using, greater than 10, or and if you use LC-MSS 10 and MESBAC greater than 7.5. I think that's a positive screen. Okay. If you use the ratio greater than 20, it's probably reasonable. And if you use the DRC, the direct rating concentration, depending on how you cut, what units you use for the aldosterone, of course, this is converting it to picomolar. It's about greater than 70. It's about 25% lower with LCMS because obviously it's more specific for aldosterone. So that is something you need to take into consideration. Now, just so this is some data, and we're creating this data. Rob Nairn's, our great clinical chemist, is doing this for us. As you can see, there's a very nice direct relationship between plasma renin activity and direct renin concentration. Obviously, what we're interested in is what's down here in this range. And for a while, we're going to do both samples. I mean, patients will come back with a plasma renin activity and a direct renin concentration, so you can get used to this new measurement. And I think this will really enhance our turnaround time. We'll get, when we order an aldo and renin now, I have to tell patients 7 to 10 days to get the results back. It's just a little longer than you would like it to be. So one of the other reasons that the committee decided that screening all patients was the natural history. The condition being screened for should have a natural history that is understood and has a recognized latent period. And I think Valia's study would show that even some normotensive patients have technically, at least biochemically, primary aldo. So we know that persons with primary PA develop organ damage and cardiovascular events if left untreated. And this is just some, again, renin-independent aldosterone secretion. Whether you call it hyperaldosteronism, I don't care, but renin-independent aldosterone production is associated with a very high risk for cardiovascular events and chronic kidney disease. The Framingham study, the higher the aldosterone, the more the hypertension. Elevated ARR increases chronic kidney disease. It increased cardiovascular risk in one study, and independent of hypertension is associated with cardiovascular health, including increased arterial stiffness, adverse cardiac remodeling, and incident hypertension. So I think it's pretty clear that when you have aldosterone secretion that's independent of renin, there's some significant problems. So the other things they want to look at is there any difference in management? In other words, does it really make any difference whether you make this diagnosis or not? But individuals with a positive screen are candidates for PA targeted therapy. So what we're really looking for here is, let's face it, I mean, if you're 44 years old and you just have hypertension, I mean, we're talking about 50 years of medications. I mean, it's a long time. But if you have an aldosterone producing adenoma that could be, diagnosed and treated with a simple laparoscopic adrenalectomy and not have hypertension the rest of your life, I think that's worth screening. So if you look at meta-analysis that look at the difference between patients who are with primary aldosteronism, patients with primary hypertension, this is all the studies put together, with a median of 9 years of hypertension treatment, the odds ratio with PA versus primary hypertension, the odds ratio is 2.6 greater time to have a stroke, 1.8 for coronary artery disease, 3.5 for atrial fib, and 2.1 for congestive heart failure. So clearly, patients who have primary aldosteronism, PA, are much more likely to have some significant cardiovascular events than patients with primary hypertension. So I think it is valuable to find these patients and treat them with targeted therapy. So the effective treatment should be available for the condition that improves outcomes if administered earlier than when a condition is apparent. So I think the guidelines will, and I'm not going to go into all the details, but specific therapy or surgery in selected patients reduces the rate of cardiovascular events, and these new aldosterone synthase inhibitors, which I think are going to be a dramatic improvement in our antihypertensive therapies, will improve the treatment of hypertension in the near future. So, and are there differences in outcomes? Well, improvement in outcomes based on management according to screening results outweighs the harms of screening. So, and I think Brad is right about some things. I mean, this you can get into some rabbit holes, but I do think that artificial intelligence and some other, and I think actually the University of Michigan is already employing some of this stuff, can really help with primary care physicians and cardiologists and nephrologists design better algorithms and paradigms to get patients to endocrinologists or whoever are experts in this area to get the right diagnosis made. I mean, for example, I just yesterday, I saw a patient referred to for adrenal vein sampling whose aldosterone concentration was, renin was 2, aldosterone was, I don't know, 70 or 60 or something, and had an elevated ratio. Well, that's not primary aldo. Of course, the reason the patient probably has was probably due to a progestin they were taking, which of course is many of the progestins bind to the MR and are antagonists. So, so I think we have to do careful screening, because targeted therapy, I think, does make a difference, particularly when you can have remission of hypertension with a unilateral adrenalectomy. But I do think those patients need to be carefully selected. So does it make any difference whether you do surgery or targeted therapy with mineralocorticoid receptor antagonists in PA? Well, this is a meta-analysis that was published just last year and looked at all-cause mortality and adverse cardiovascular events and showed that it favors surgery in patients with aldosterone-producing adenomas versus medical therapy. So I do think it's beneficial to go to the trouble of selecting patients who may have unilateral aldosterone hypersecretion and may benefit from an adrenalectomy. So it looks like early screening for PA probably does improve outcomes. At least cost-effective studies in Japan, China, and Australia have shown that. It turns out I think patients really want this, and believe it or not, I think primary care providers want it too, because hypertension. I mean, how many million was it? Perhaps 48 million people have hypertension, whatever the number.
22, yeah.
Huh?
122 million, yeah.
122 million. So I mean, this is something they have to deal with. So why not? Somebody with new onset hypertension, why wouldn't you want to screen for this? It's just, I don't understand for the life of me why, I mean, I can understand you're 82 years old, maybe not, but if you're 45 years old, you have new hypertension, it makes a lot of sense to screen for this. And I think subtyping patients still remains important to provide appropriate targeted therapy. Now, of course, I can't talk anywhere without mentioning cortisol, since it's really so much more important, I think, than aldosterone. But it's also important. It's also important to know that it circulates at 1,000 times greater concentration, but it has exactly the same affinity for MR. So thank goodness for 11-beta hydroxysteroid dehydrogenase type 2, because it protects the MR from cortisol. But a lot of work now is showing that declines in age and eGFR impairs 11-HSE2 activity, and so gives cortisol more chance to bind to the mineralocorticoid receptor of the kidney, and may be a significant contributing factor to hypertension. And the Catalyst study, which I've talked a lot about at various talks, which just got published, 3 a month ago, showed that, in a poorly controlled diabetic population, A1C is greater than 7.5% on multiple drugs, 24% of them had abnormal dexamethasone suppression tests. But patients with hypertension, resistant hypertension greater than 3 drugs, it was 37%. So certainly cortisol excess also contributes to endocrine hypertension. And hypercortisolism is common in the Bell-Box syndrome, and it's just unbelievable. I mean, if you look at, this study in 2003, which was obese diabetic patients with A1Cs greater than 8%, I thought this was going to change everything. This is Cartaghi from Italy. In fact, I remember at the Endocrine Society meetings, I went up to him and I said, "Oh, thank you," because I've been saying this for like a long time, that we should look for hypercortisolism patients who have the metabolic syndrome, it changed nothing. Stevenson, 2019, abnormal DST, 22%. Costa, 393 diabetic patients with vascular complication, 33%. Chidini from Milan, 17%. So clearly, the fact that hypercortisolism is a very common cause, a very common component, whether it's a cause or not, of the metabolic syndrome cannot be understated. And this turns out to be important because this study, which this has not been, this will be published first week of July probably online. Part 2 of this study showed that mifepristone versus placebo, mifepristone treatment, glucocorticoid receptor antagonist, of course, reduced A1Cs by 1.5%, placebo negligible change. And the presence or absence of adrenal nodules, which were present in about 34% of these patients, didn't impact the response to GR antagonism. So pretty clear now that even non-neoplastic hypercortisolism is probably important in diabetes management and probably in hypertension management as well. And that's going to be found out by the Momentum study, which again is going to start very soon. And we're going to prospectively screen 1,000 patients for hypercortisolism with resistant hypertension, including, of course, primary aldo will also be screened for in 1,000 patients. And the enrollment will start soon. And I will predict that not only will, of course, a lot of patients are going to have PA, but a lot of patients are going to have hypercortisolism as well. So my conclusion is that by 2050, I won't be alive, so you won't be able to say I was wrong. But that hypertension will be considered adrenal hypertension until proven otherwise. And I think we have time for lots of questions. Brad can come up here and we can discuss.
Okay, I'll stay here.
No, we still have 15 minutes or so. But I just think that, in fact, I remember being at this meeting for the Momentum trial, and we were planning it and of course, all the people in the room, none of them are endocrinologists. For some reason, I mean, if you go very few places in the country where hypertension is they have hypertensive experts or hypertensive clinic, or it's never run by endocrinologists. It's always run by cardiologists, nephrologists, or some people that are a combination of both. So everybody in the room that's doing this study is not an endocrinologist. And the guy from Penn, very bright guy, very well known in this area, he says, yeah, I noticed that all the patients who have resistant hypertension have low renins. I said, well, I mean, it's no surprise. And that's why spironolactone or prilonone are such effective therapies in that group of patients. And the addition of aldosterone synthase inhibitors is just going to be another great advance, I think, in the management of these patients. So I think that the concept of primary aldo, I mean, what we're really targeting is trying to find these patients with adenomas that can be, cured with, hopefully, or certainly significantly improvement with adrenalectomy. And if we can find algorithms and AI using AI or to select out patients who are more likely to have that, then I think we'll, and then the other patients who we think are not very likely to have it, just treat them with an MR or antagonist or maybe with one of these new aldosterone synthase inhibitors, which are going to be a lot more expensive than spironolactone, I can assure you. I think will provide patients with much better outcomes in terms of blood pressure control and less cardiovascular events in the future. So that's my hopes. So I think endocrinologists, we're going to be involved in this. I mean, I think I didn't get much training in hypertension and primary aldo as a fellow. I was focused more on the pituitary adrenal stuff with Cushing's disease, but I really think this is an important for all of us to understand and help our cardiologists, primary care physicians, nephrologists understand this so that our patients can have the best outcomes possible. Thank you.
All right. So thank you. Great presentations. We'll take some questions from the audience. And if
Yeah, I think
you're
so.
virtual and you want to unmute and ask a question or put in the chat, please go ahead. I guess I'll start by asking. So if I'm going to screen either high-risk patients or everybody with hypertension, what should I use for my what's a positive test, or what should I measure? What should I use?
Jay, you want to? So,
Well, as I just said, I do aldosterone and renin, and of course, a metabolic panel. Obviously, you need to do a potassium level. I think sodium levels can also be. My guess is when the AI models get built, that the sodium concentration may also matter, because if you look at patients with PA, particularly if they have an aldosterone-producing adenomas, their serum sodium is almost always no less than 140, and often about 140 to 143. So direct therapy may sometimes obfuscate that, but I mean, I think I would just start with an aldo, renin, and a metabolic panel, and again, I just think we get too caught up in the ratios. I'm not a ratio guy. I mean, because these ratios. I mean, Jack, did you see that patient? I think you did see that patient with me. Plasma renin 2 is a ratio of 25 or 30. It's not, so people are too focused on this ratio and not focused enough on the fact that we're looking for patients with low renin hypertension.
Yeah, I would agree with that. I would say instead of focusing on the ratio, which is all over the place with the way where it's tested, I think I agree with looking at aldo and renin separately, and I think we probably, to guide people, we're going to need some kind of cutoff, because if we just make it all these gray areas, we got to give some guidance. And the new guidelines, I didn't go into this because of course I wanted to save it for Dr. Findling, but the new guidelines do come out with an aldosterone to renin ratio recommendation. They recommend 20 and they recommend an aldosterone of 10 as a cutoff. So the previous guidelines, they kind of were very iffy about where to cut it off, but the new guidelines say use 20 as the ratio, 10 as the aldo, less than 1 for renin, and so that's kind of where they kind of settle out.
But I'll just give the caveat. I think the aldosterone values can vary. So in that Brigham study, they looked at patients with primary aldosteronism with confirmatory testing as positive, and they looked at different aldosterone values, and it's ranged from 5 to higher in patients with proven primary aldosteronism. So I think 10 is a good cutoff in general, but if somebody you have a high suspicion for, I think anything over 5 could potentially be aldosteronism.
Before I walked here, I'm not making this up. I don't know if Brent Jones is probably not listening, but everybody probably knows Brent. He's an endocrinologist on the east side, and I got an email from him. He said that patient with incidentaloma, aldo's 5, renin is undetectable. What should I do? I mean, it's the same kind of story. And I said, well, what's the potassium? What time of the day? Because it also matters what time of the day. Aldosterone does have a little bit of circadian rhythm, so the morning aldos are a little bit higher. So, 5 and undetectable, I said, repeat it in the morning, make sure the potassium's robust, and then, because she's going to do the DST, of course. But, I agree. I'm telling you, adults in the United States shouldn't make any aldosterone. I'm so shocked that we can even measure it in most people. It's just, with the sodium diets that we have, the processed food and everything else. And really, histologically, you can't find cells in the adrenal cortex that any contiguous zonic glomerulosa in adults. In children and rodents, I guess you can, but not so much in adults. So I think an aldosterone concentration of 7 with an undetectable renin, especially if somebody's on a losartan or an ACE inhibitor, that should, your ears should go up, and this patient probably has primary aldo, and the question is it neoplastic, or is this somebody who would just improve with targeted therapy with the MRA? Then you just have to make some clinical decisions based on, age. Imaging obviously doesn't, you kind of go down rabbit holes looking at imaging, but I think the big rate limiting step, let's face it, is adrenal vein sampling. There's no question, and it'll there are many places now, including where we're very fortunate. We have great people doing it here. But in rural Mississippi, they have just as much PA as they do here, and my guess is they don't have adrenal vein sampling available. So
can I
yeah.
Can I ask a question?
Sure.
Can you hear me?
Yes.
So I have a question and a comment. So what percentage of hypertensive patients would meet any of those criteria you mentioned, Brad?
Well,
And
so there is one. So yeah, so there was one study where they just looked at the ratios, and so the percent that would test positive, and then another
that's not
one.
the
If you
question
just
I'm
look,
asking, Brad.
wait,
If you take all the patients that would qualify for screening under the list that you gave, 3 drugs, sleep apnea, blah, blah, blah,
Yeah.
and divide that by the number of hypertensive patients, what percent would qualify for screening?
So if you look at the 2016 guidelines, if you look at that list of reasons to screen, it's somewhere between 40 and 50% of all people with hypertension. So if you follow the guidelines, we should be screening 40 to 50% of all people.
Okay. So my comment is the problem with those guidelines is they're difficult to operationalize. People won't remember those things. So the only way to operationalize that is that if you have hypertension and your EMR has all the other data, if the EMR were to tell you, okay, the patient needs this done, because primary care physicians are not going to remember those criteria on a consistent basis when patients come into their office. So it strikes me that if we want to use the indications for it, it has to be electronically, like the bone density. You've hit 65, you get a bone density. This is okay. You've hit 3 drugs, you get a PRA and Aldo. You also have sleep apnea. You got a PRA and Aldo.
Yeah, I mean, you're right, Joe. It's going to take a long time. That's why I said 2050, because it's good. And I'm not being even facetious. I wish I was being facetious about that date, but it takes a long time for things to change. A long time. I mean, it really does take a long time.
Well, I think I disagree though a little bit. I think, there's so much in medicine that's complicated, and it's kind of talking down to primary care, in my opinion, to say, well, it's too complicated to think, oh yeah, this person has really bad hypertension and an adrenal adenoma and low potassium. They should be able to think of. I think they can do it. I think that they can think about the higher risk people, and helping them with the best practice alert. I think is good and all, but
Brad, they don't know that the CT scan done by GI showed an adrenal adenoma.
Right. So I think
because
definitely
it wasn't
AI,
even mentioned on the CT scan.
Right.
But even
Well,
if it was mentioned, Brad, they have 15-minute follow-up visits. Okay?
Yeah.
There is
But
no way they're going to look through all that imaging.
So then they should
It's
refer
not
everybody.
Well, let me tell you. I'll tell you
an
what's going to change.
endocrinologist.
I'll tell you what will change everything. I'm going to tell you what's going to change. It's like what happened with Cushing's, because let me tell you, I was in the wilderness for 2 or 3 decades, but until the pharmaceutical industry got interested and started had pharmacotherapy to treat hypercortisolism, that's when all of a sudden, the interest started.
He's right.
That's when people, it's
That's when we were. That's why we've been blessed with hypertension.
Nobody did bone density. Nobody did bone density because, when I was a fellow, you couldn't even do bone density. I mean, it didn't even exist. But nobody did it until they found out that osteoporosis was a Fosamax deficiency. So once they found out that it was a Fosamax deficiency, screening
and
became,
then industry
they would
convinced us we should treat patients who were at almost no risk for fracture, and they were involved in the guidelines. So that's another issue. But you're right,
I mean,
Joe.
but when aldosterone synthase inhibitors become,
You're going to hear a lot about aldosterone when they
all of
come
a
out
sudden,
on the
because, and now,
and when testosterone came out, everybody had low testosterone.
and these companies, and you got to realize that these companies, and Brad's right. I mean, if you read that what was it, April 20, that largestat, yeah, that article, the first sentence is, aldosterone dysregulation is maybe a contributing factor to hypertension. But they never measure aldosterone, and these companies aren't going to do that because they don't want you to measure aldosterone. They just want you to put everybody on these drugs. I mean, but I think what's going to happen is that people are going to say, "Gee, I'm starting people on an aldosterone synthase inhibitor. Maybe I ought to know what the aldosterone level is." So maybe that'll make a difference too. I don't know.
But yeah, it just seems like whenever a new drug comes out, everybody's got the disease. 25%, 50% of people have the disease all of a sudden that we didn't realize.
Yeah,
some disease.
Well, I mean,
so we might be overdiagnosing.
Are you autistic or what are you?
What's that?
Are you autistic, Brad? Or? No, I'm just giving a joke.
Okay, I get it.
No.
A bad joke, I guess.
Yeah.
But yeah, I think this is going to. I think just the idea that there's a new drug that specifically blocks this enzyme is going to have an impact on screening. I think that will have an impact on screening, even though they will not mention it in their package insert.
Jay, I think you might be wrong on this part of it. I think it's just like with Fosamax. They didn't want anyone to get tested for why. They just wanted everyone to go on the med.
Yeah, okay.
Because testing people confuses them. So I'm not convinced you're right that'll lead to it. But I do think, Brad, I think we need to help the primary care physician. Not because I'm not trying to speak down on them. I'm trying to recognize they can't look through every CAT scan report. They're not going to be able to find all the stuff. If it pops up, if this stuff is captured by EMR or AI or something, then I think we'd be much better off. Yeah, I think, yeah.
All right. I am going to cut off questions now because we're a little after 5, but thank you very much. Good job. Call it a tie. Neither one of you can get fired.
Yeah, so we'll send you. Oh no, your alpha.